I think it's going to be an extraordinary topic today, which has become more and more interesting as well as controversial. Women, cardiovascular health and disease, there is a gender difference. When we were initially planning today's presentation, I thought we could make it Mount Sinai Women's Heart Health Day and sort of showcase all of the women we have on faculty. And as we started doing, and it became larger and larger faculty, we realized that we have over a third of our faculty are women. And importantly, women are in very prominent positions in cardiology. Head of the cath lab, head of cath lab research, head of the echo lab, very prominent roles in heart failure, in vascular imaging. We are really a very diverse group, and I give a lot of credit to Dr. Fuster for hiring a very diverse but outstanding faculty. So I have to apologize because we had started with Dominic and I were working, and we started, and as it grew to so many, we had to cut back on the women on the panel. And it doesn't mean that women exclusively take care of women, but I thought it was a great opportunity to really have experts who are women be on the panel. So I apologize to anyone and everyone who I've insulted. I'm sure I've insulted a lot of people over the years, but this particularly event, because we really, I think, are looking forward to an outstanding evening. I wanted to acknowledge and just introduce briefly the moderator. Normally, I'm in this position introducing Dr. Fuster, and I rarely introduce him because it would take me probably a day and a half to give all of his accolades appropriately. But he kindly has acceded today's moderating to Dr. Roxana Moran. I just wanted to take a moment to acknowledge her achievements. At ACC 2017, she was recognized with the Bernadine Healy Leadership in Women's Cardiovascular Disease Award. And at that time, Greg Stone said Dr. Roxana Moran has helped transform interventional cardiology and advance gender-based understanding and opportunities in medicine, all of the hallmarks of a worthy recipient of this award. Just as a plug, as part of the diversity in hiring, Dr. Fuster hired somebody from Columbia to come to Sinai, Greg Stone, who just joined our faculty a few weeks ago. I just finished a meeting with. Is going to be a great addition to our program. Dr. Moran is the Chief Scientific Officer of the Cardiovascular Research Foundation, is a professor of medicine, cardiology, health evidence, and policy at the Icahn School of Medicine here at Mount Sinai in New York. And she has led or served on the steering committee in more than 40 clinical trials, has published more than 800 peer-reviewed articles, has co-authored over 600 abstracts. She also co-founded the Women in Innovations Initiative, which focuses on mentoring the next generation of female interventional cardiologists. She's, in addition, she's Director of Interventional Cardiovascular Research and Clinical Trials at the Zena and Michael Wiener Cardiovascular Institute. And over the last 6 years, she has led the development of globally respected Data and Clinical Coordination Center to support large multi-center, multinational clinical trials. As we all know, Twilight was just published in the England Journal of Medicine, a landmark trial on antiplatelet drugs. And what you don't know, Dr. Moran was just nominated to the ACC Board of Trustees for this coming year, and also will be receiving in just a few weeks a chair professorship here at Mount Sinai. So I normally don't take the time and effort to spend that much time on introduction, but I thought it was certainly necessary and noteworthy considering Roxana's recent achievement. Unfortunately for Fahad, I don't have as large an introduction, but Dr. Fahad put in almost as much time as my introduction could have said, but he is a great fellow here. We're very happy that he came here from Stanford. He's a second-year fellow and put together really, I think, outstanding monograph. And these monographs very frequently get published in a peer-reviewed journal that we fully expect he will do. So without further ado.
Hello, everyone. Thank you, Dr. Goldman, for the introduction, to Dr. Moran for moderating, and to Dr. Oyang for visiting today and assisting with our discussion. My name is Fahad Yunus. I'm a second-year fellow here in cardiology, and I have the privilege of introducing today's topic for controversy in cardiology. Cardiovascular disease is the leading cause of morbidity and mortality for women in the U.S. and globally. In the U.S., over 6.5 million women are affected by cardiovascular disease each year. Over the past 3 decades, there have been significant advancements in cardiovascular disease and a trend towards decrease in mortality overall. However, despite these improvements, women continue to experience disproportionately high mortality rates compared to men, most notably women less than 55 years of age. The review provided and the discussion today will attempt to address some of the factors associated with sex-based differences in outcomes from cardiovascular disease. Addressing heart disease in women involves discussing both the impact of traditional risk factors as well as an understanding of non-traditional risk factors unique to women. Awareness of cardiovascular disease in women is increasing steadily, but there remains significant room for improvement. Physicians often underestimate the risk of heart disease in women. Even if diagnosed with risk factors, women are more likely to receive suboptimal care as compared to men. Compared to men at similar ACVSD risk, women are less likely to receive preventative treatment or have guidance about lifestyle modification and changes. Cardiovascular care in women is less often intensive, with women referred less often for cardiac catheterization than men. Despite the high prevalence of cardiovascular disease among women, diagnosis can often be challenging. Women are more likely than men to present without chest pain, and ACS in women is often accompanied by subtle prodromal symptoms such as nausea or shortness of breath. These differences in presentation have consequences for timely identification of ischemic symptoms. Inattention to these subtle differences or an inability to appropriately triage early can result in misdiagnosis, delayed revascularization, and higher mortality rates for women with acute myocardial infarction. Even after correct diagnosis of ACS, women are less likely to receive intensive therapy compared to men. Among women aged less than 55 years presenting with ST elevation MI, were less likely to receive reperfusion therapy and more likely to have reperfusion delays than men. Newer guidelines are addressing the infrequency of invasive management for women presenting with ACS, with the most recent ACC-AHA guidelines providing a Class 1 level of evidence A recommendation for an early invasive strategy for women with high-risk features presenting with NSTEMI, which has been proven to improve mortality. It is important to have an understanding of the risk factors for manifestation for heart disease in women. Traditional risk factors for heart disease include those seen in both women and men, such as hypertension, diabetes, hyperlipidemia, and smoking. There are, however, certain unique risk factors for development of heart disease in women. Adverse pregnancy outcomes such as preeclampsia and gestational diabetes mellitus have been associated with an increased risk of development of cardiovascular disease, even decades postpartum. The complicated effects of sex hormones on development of heart disease and the hypothesized protective role of estrogen continues to be an active area of investigation. Identifying modifiable risk factors can provide areas of emphasis in improving preventative care for women. But discussion of ischemic heart disease in women should encompass not just obstructive epicardial coronary disease, but also focus on microvascular dysfunction, spontaneous coronary artery dissection, or SCAD, and myocardial oxygen supply-demand imbalances. In fact, extensive non-obstructive coronary artery disease has similar rate of adverse events to that of obstructive coronary artery disease, and these entities warrant further investigation. Encouraging the enrollment of women in clinical trials and the reporting of sex-specific outcomes are public health focuses. They've been highlighted recently by both the Institute of Medicine and the Food and Drug Administration. But despite these public health emphasis, a lack of reporting of sex-specific outcomes and underrepresentation of women in clinical trials is seen throughout the cardiovascular literature. The disparities in outcomes among women with cardiovascular disease highlight the gaps in our current evidence base. Further research aimed at identifying sex and gender-based disparities can guide clinical care and improve health for women in the United States and throughout the world. Thank you.
Thank you very much, Fahd, for your presentation and the manuscript that you have. A lot of work. It's a pleasure to introduce a very good person, outstanding individual. He is Dr. Pamela Wang. I know Pamela very well since she's an associate editor of JAG, and she has done a wonderful work for us. Let me go back very quickly because there is not too much time today for the controversies. She was trained in the United Kingdom. She had the equivalent of college at the University of London. And then she had her medical degree at St. Bartholomew's Hospital in the United Kingdom. Was a house physician. It was the equivalent of a resident here or intern resident. And eventually she had her fellowship in 1978, actually at Johns Hopkins. And she has been at Hopkins since then. Now she began as assistant professor, associate professor, and then professor of medicine. And she began actually being the director of the cardiology outpatient service. Then she was the director of the general clinical research at Hopkins, and then eventually translational research program director. Now, she has a lot of accomplishments, and I think I have to be short here. She has been very well funded by the American Heart Association and by NIH on a number of very significant studies related to some of the aspects I will mention in a moment. She has been part of the American College of Cardiology and also with the AHA on a number of positions, study section of NIH, and as I mentioned, associate editor of JAG. Her curriculum, her bibliography is fascinating. She has over 200 papers about any subject that you can think about in the cardiovascular field, from the electrical aspects, heart failure, cerebrovascular disease, coronary artery disease, etc. But there are three main themes that she has been involved with. One is the effect of hormone therapy in coronary artery disease that was presented this morning, or this noon. And there she really did a lot of basic science work related to antioxidant, vitamins, endothelial function, etc. The second aspect is she's part of the MESA study. All of you know what is MESA. And there she got into actually the preventive aspects of cardiovascular disease, inflammatory biomarkers, adiposity, and other aspects for the prevention of disease. And the third theme that she has been very involved, of course, is the theme of women's health as a discipline beyond obstetrics and gynecology that she said. I could go on and on. I don't think it's necessary. I hope you got a feeling of the person that we are dealing today, and I'm very pleased that I think you visited Mount Sinai for the first time, and congratulations for your presence here. We are all very proud, and let me give you this for you to remember your visit, which is Pamela Wang for outstanding teaching, wisdom, and expertise as the Nandi Sharma Visiting Professor and the Simon Duck Memorial Lecturer, October 28. Congratulations.
Thank you.
I'll give you this. Sure. Okay. And now I have to, you can actually sit in the middle there. Thank you. And I give you this. Okay, thank you. So, Roxana, of course. Lala is here. Daniela is here. I saw her. Anu is here. I also saw her. Amy, I didn't see. Is Amy here? Yeah, thank you. Marie-Noël, yeah. And then Marianne. And Gina La Roca is also here. Okay. So, okay, Roxana, is all yours.
Thank you, Dr. Fuster. Thank you. Good afternoon, ladies and gentlemen. What a pleasure to welcome a very, very incredible woman in cardiology Dr. Pam Uwang to our hospital. Pam and I know each other for a long, long time. I'm not going to say how long, but long enough to note that we know each other, and I've been very lucky to be in your circles and to learn from you as a true role model for us. I wanted to begin by just going through some facts, some things we're going to discuss. We're only going to go till 6 o'clock because Dr. Uwang has a train to catch, but let's just go through this, and these are the kinds of things we're going to discuss today. Coronary artery disease, leading cause of mortality in women in the world. More than half of the population of the world is occupied by women. More women between the ages of 35 and 54 are admitted with an acute myocardial infarction than men. So younger women with acute myocardial infarction, much more often seen than men. The lifetime risk of atrial fibrillation is higher in women than men in many regions of the world. Noel will be asking about that from you. Stroke, the second most common cause of mortality in women. That'll be Daniela's big part. Women with heart attacks are twice as likely to suffer a decline in thinking and memory skills. And I know this is something that Dr. Fuster talks about, the heart and mind relationship. More than 90% of reported cases of Takotsubo cardiomyopathy occur in postmenopausal women. Women have higher prevalence of PAD-associated mortality. Women are more susceptible to radiotherapy and chemotherapy-associated cardiotoxicity. The entire field of cardio-oncology, for which we now have a cardio-oncology journal for in JACC, is a very, very telling story for women. And female patients receive only 25% of the heart transplants, yet there's a tremendous number of women who suffer from heart failure, especially the preserved ejection fraction. And young women are less likely to be aware of their risk of heart disease. These are just some of the topics we're going to discuss. But let me just say, as you mentioned, Mount Sinai is a very rich place with a lot of women, and we are so lucky to have these incredible women on our panel. Thank you, Dr. Fuster, for your vision of bringing all these women into your department to make it so much richer, so much better, so much more exciting to be here as part of this group. We have Dr. Kinney, director of our cath lab, professor of medicine. We have Dr. Katie Endodov, an incredible cardiovascular disease specialist, but very much into vascular medicine. Amy, are you here, Dr. Controversies? Yes, I didn't see you. Really dealing with a lot of important channelopathies, sudden cardiac death, some of the connective tissue disorders, et cetera. Noel Langen, I trained under you, Noel, an incredible woman in arrhythmia and electrophysiologist. Gina LaRocca, an incredible, brilliant woman, associate professor of both medicine, cardiology, and radiology. Wow, we have a lot of underachievers here and dealing with adult congenital heart as well as CT. And my colleague, dear friend, Marianne McLaughlin, what an amazing woman. 2 appointments, several grants, incredible woman that knows so much about everything. We have an amazing panel, ladies and gentlemen, and a lot to talk about. So lots to just dive into. And let's begin with prevention. Pam, I'm going to ask you, Dr. Uwang, is there really an important difference in the cardiovascular risks that we should be thinking about in women? I know you've focused a lot on pregnancy-related complication as you know, we know the usual risk factors, we're gonna talk about them, but I'm gonna dive right into the important risk factors that we might not be thinking about. You wanna tell us a little bit about that? What should we know? If there's one thing we need to learn today, what should we take away from you being present here with all the work you have done?
Thanks. Well, I think that one of the important messages is that we should ask a reproductive history. So pregnancy complications, by the time women come to see us as cardiologists, often they're in their, sometimes in their 50s, but often in their 60s. It's by that time, it's not necessarily routine to be asking about pregnancy complications. But the data is very strong that adverse pregnancy outcomes, particularly preeclampsia, gestational diabetes, and even early for gestational, small for gestational age babies confer on the mother an increased cardiovascular risk of a threefold increase. So I think that there's a couple of things. One is that we should ask that question, but also if we're seeing women during those complicated pregnancies, an effort needs to be made to educate the woman so that she carries that information with her, because women through their reproductive years, once they have had their baby, often will be changing the physicians that they see. They no longer just see their obstetrician, may see an internist, then it could be decades later that they see someone when they really feel that they need to have more longitudinal care. And without them realizing the importance of that history, they don't necessarily provide it.
So is the understanding correct that there is definite association, but the causal relationship has not been well worked out? Is that an honest, correct statement or not?
There's an association that I think that's very clear. The question that is not so clear is what is the pathway as to whether it is that during pregnancy the risk hypertension is found and then it goes away once the woman delivers. Is it because the future cardiovascular disease, maybe because that woman is so much more likely to develop high blood pressure over the subsequent decade and develop diabetes in the subsequent decade, and then maybe it's those that are conferring the risk? Or is it something specific to vascular properties that has been identified by the preeclampsia? So that we don't have excellent ways of following women longer term in cohort studies of women with adverse pregnancy outcomes to be measuring these characteristics on the same population. So it often is that there are population cohorts that are looking backwards, but not too many that are following the patients.
So the takeaway is, think about when you see pregnancy-related complication, it matters in a woman. They should know about it. We should know about it, and we should ask about it, and perhaps survey them a little bit closer and be more closely attached to that. Danielle, what do you think about the vascular issues that comes into play, especially hypertension in women? Should we be looking and treating hypertension differently in women as we do in men? And for stroke prevention and vascular disease and in your area?
Sure, yeah. So I think, number one, we should be as aggressive as treating hypertension in women as we are in men. And I think in general, we don't do as good of a job of reducing risk factors in women as we do in men, as Vahid was mentioning in his talk. I think additionally, there are other things to consider when seeing particularly younger women with hypertension, including those with preeclampsia that persist after pregnancy, and specifically thinking about non-atherosclerotic causes like fibromuscular dysplasia, and perhaps screening for that as a risk factor for stroke. I'm sorry, I think I missed the last part
I
here.
think that's where I'm going with that, is that this relationship between vascular disease and then stroke prevention, and then of course hypertension being such an important part of this, especially in the African American women. Does anybody want to comment on that? Marianne?
I think another risk factor in women that's underdiagnosed is obstructive sleep apnea, so OSA. So we commonly see it in middle-aged to older men, and we have a certain body habitus, but premature menopause, so menopause at age 35 or lower, is an increased risk for sleep apnea. Change in hormones postmenopausal women has an increased association with OSA, and OSA is associated with hypertension. One thing I was going to say about menopause, I think one of the take-home messages is that as asking that history, not only about, in my office, we ask about, what were your pregnancies, did you have preeclampsia, et cetera, but also what was your age at menopause and what were your symptoms. So vasomotor symptoms, increased vasomotor symptoms at menopause correlate with increased coronary calcium scores. That was a part of the SWAN study findings. But studies here have shown that vascular calcifications in the breast are associated with increased coronary calcifications. So those are types of questions to talk about and think at and work with our OBGYNs to improve the diagnosis at an age when women are coming in with some palpitations, nonspecific symptoms, and we're not digging for the true risks and treating the risks like aggressively early on.
No, this is a really, really good point. And so you went right into the imaging of women. Marianne, I'm going to come back to you again. When do you order a calcium score, if at all? There was, Marianne McLaughlin, I'm asking you. Yeah, and then I'm going to ask Gina. No, because then Gina will tell us what we should do. So I want to hear about the imaging because you went there. I wasn't going there, but now that you're there, I'm going to bring you there.
Sure.
So when do you and how do you, because, the studies are scaring a lot of the young women about radiation and all of that. So we need to educate everyone. Who gets a calcium score? Who gets a stress test? And who gets, as you're looking at these women?
When someone's in my office and I do an ASCVD risk score on everyone in the office, if their ASCVD risk score is elevated, I also talk about doing a coronary calcium score. That's a number one. I do it in people with a family history of premature CAD, and I do it in, and if they have an increased coronary calcium score, I'm also going to do a stress test. So I go along that lines even if they're asymptomatic, if there's a strong family history. I just have a quick anecdotal story. So this happened this weekend. I met a woman who said she and her husband in their mid-50s went to see a cardiologist at a different institution for risk prevention. And she had an EKG that had a left bundle branch block. And she was very healthy. She was a tennis player, very fit, very thin. And he did her cholesterol panel. And she had a loud murmur, but he never did an echocardiogram. On her husband, who didn't have any risk factors, he did an echo and a stress test and a coronary calcium score. So she followed him for years and he saw her she needed her thyroid taken out. He cleared her without an echo or a stress test or anything. So it turns out over the years, she started getting a little bit short of breath. She came here and she was diagnosed with HOCM, and she really had been missed. And she just had surgery, and she's been treated. But she said, I can't believe that cardiologist, he just looked at me and my husband and treated us very differently.
Right.
And she had a life-threatening, she had a left bundle, she had a loud murmur. And so those are the things that, just to say that we have to treat everyone with the same amount of preconceived risk.
So Gina, how did she do? Is that a way to go forward for women? And should it be different than men?
I'm glad that she saw you finally, lucky woman. Pleasure to be here. I think just one anecdote, JACC Imaging had a great publication in April 2016. The whole journal was dedicated to cardiovascular imaging in women. And so I think there's a lot of excellent reading in that particular journal. There is no right or wrong answer here. I think one thing I'd like to step aside and say that we should not forget about microvascular disease in women. And I think imaging plays a major role in that. Aside from the stress test, the nuclear stress test, and the calcium score that we could do, we could risk stratify that way and look for ischemia. Women with microvascular disease have normal nuclear stress tests, may have a low calcium score. And this is a lifelong minimal stenosis that goes on, and I think the reason why women have microvascular disease more often than men, it's almost like a 75-25% ratio, is that we have smaller coronary arteries because our LV mass is smaller. We have higher coronary blood flow because of that, and we have higher endothelial wall stress. And when you combine all of that, women go along with this microvascular coronary disease for years not being treated. So how do you make the diagnosis? It's difficult. And I would say one plug for cardiac MRI, phase contrast imaging for coronary blood flow. But of course, we would start with something simple with a calcium score and stress test. And it could be stress echo. There's a publication today out in JACC that looked at stress echo and coronary flow velocity reserve.
So Pam, where do you stand on this regarding the microvasculature and imaging to decipher what is really going on in some of these women? It's a very, very difficult area. So I want to make sure we capture that from you before you leave us.
Well, it is difficult. I mean, these are women with chest pain, anginal symptoms, frequently exertional chest pain, and yet have no significant coronary artery disease, and you're trying to decide whether this is truly important. What I've done is to do MR, which will, along with hyperemic agents, will result in an absolute measurement of coronary flow. So that, as we were discussing earlier this afternoon, requires specific protocols that are not necessarily in place everywhere. But that's, usually what I've done, if the patient gives a very strong history that clearly shows that they've had an ischemic episode, so they've been admitted with chest pain, troponin rise, EKG changes, and a non-obstructive coronary angiogram, then I'm going to assume that's what we're dealing with, and not necessarily do additional MR studies.
Yeah, so, it's a very difficult area because women with MNOCA or ANOCA have a much higher mortality down the line, no matter what we do. And I'm not so sure that we have a treatment paradigm for them. And maybe you can comment on that.
Well, I agree with you that there are no sizable studies of any intervention. So there's, the WISE study has shown in small cohorts of women some symptomatic improvement with beta blockers. I usually start there, particularly if they have exertional symptoms. Whether or not statins may help, some ACE inhibitors may, but we really don't have large enough cohorts to adequately distinguish the outcome from different therapies, I think.
Yeah, now, so staying with that, with chest pain syndromes in women and presentation of acute myocardial infarction and STEMI and non-STEMI. Dr. Kinney is our interventional cardiologist here. We know that women are brought in later, they wait longer, they're treated a little bit later, and then the anatomy is very, very different. Dr. Kinney, do you want to just tell us how often are you seeing Takotsubo? Are you seeing it more often now in the cath lab? And secondly, are you looking for SCAD, spontaneous coronary artery dissection? These two areas are incredibly important. Previously, we weren't paying attention to it, but we're seeing it more and more often if we look for it. Do you want to comment on that, and then on treatment differences, if there are any, for women versus men?
I think, as discussed, women presentation definitely could be different, especially if they're presenting with STEMI or ACS, and that is why I think studies, as well as all the time, why women have done poorly is because of late presentation. They don't come to the hospital on time, and even when they present because of atypical symptoms, probably diagnosis is not done on time. But STEMI, there is no difference in, whatever it is, once a diagnosis is made, the treatment would be the similar for patient. Now, is there a difference between men versus women? Definitely we see more Takotsubo in women, and always there's a correlation with stress. That is where history is very important. But I think if somebody is presenting with an EKG change, with some chest pain, the only diagnosis is after having done a cath. Sometimes when it is questionable, we'll do an echo in the ED, which will give us an impression that likely it could be Takotsubo's disease. And of course, since we are a center for treating SCAD, if the angiogram does not look like a typical STEMI, non-STEMI, where you see a lot of thrombus, then we will think about, could it be a SCAD? We have seen both men and women, but yes, definitely more in women, but very rarely we have seen a couple of SCAD cases even in pregnant patients.
Yeah.
But once we have seen them, treatment-wise is no different. You know, you would give the same antiplatelets, same anticoagulation, and the stents, they're no different. But we definitely have seen complication rate, which is especially bleeding, is higher in
And in some
women.
cases, you might leave them alone, right, to allow the dissection to heal.
Yeah,
Danielle, you
definitely.
wanna tell us that what you're doing with SCAD so that everyone knows and thinks about it and
Absolutely.
gives to your registry?
Yeah, absolutely. So, so yes, we're now enrolling as part of the International SCAD Registry. Sinai was the third site to start enrolling for that. So if you have patients, please have them come see us. But most often for SCAD, thankfully in many cases, intervention's not necessary and patients tend to do well with conservative management. If they have poor TIMI flow, or obviously they present with a STEMI or cardiac arrest, that's a different situation, and the normal pathways to revascularization apply. In terms of management of SCAD patients after the event, because of the very close association with fibromuscular dysplasia, meaning when patients are systematically screened, we identify it in somewhere between 50 to 80% of patients. Every patient with SCAD should get a CTA from the head, neck, chest, abdomen, and pelvis to look for fibromuscular dysplasia and also for any aneurysms or dissections. Actually, you can see cerebral aneurysms in up to 14%,
So that's a really important association. And Pam, did you want to comment?
Yes, I just wanted to ask whether you use CT angiography. If the history was strong enough for either Takotsubo or for probable SCAD, and the patient was hemodynamically stable, would you consider that as the first approach, or would you always go to the angiogram? Or both?
From my perspective, angio would be necessary because you can miss SCAD with CT angio. So catheter-based angiogram would be the way to go.
And in times, in our lab, we do some intravascular imaging where we really make the diagnosis, and that's what Dr. Kinney would do, because sometimes even the angiogram with a 2D angiography, you could miss a lot of that. And there's a lot more SCAD than meets the eye, and that's really sort of what we need to kind of take away from here. And importantly, these women will have a poor outcome, and we need to kind of maybe get more and try to understand better. I want to now.
One more thing.
Yeah, sure,
Sorry.
please.
Just a comment about Takotsubo and SCAD. SCAD
Yeah, I
can
was
also
going there
cause Takotsubo. So if you have a wraparound LAD, that may be the lesion resulting in Takotsubo.
Right, and so Takotsubo, and maybe Dr. Fahd, you could tell us what you learned about Takotsubo. Why is it happening more often in women? Did you learn anything there in the literature?
Thank you, everyone. Well, I think the biggest thing for Takotsubo is kind of, as we discussed today at noon, is just the association between it presenting in postmenopausal women. So to always have that, I think, index of suspicion when a woman is in that kind of demographic is presenting in that age group. Because if you don't have that index of suspicion or aren't thinking about it, then you won't make the diagnosis. I think that's. And then as far as why it's occurring in that age group specifically, a lot of the research has been looking into associations with a predisposing risk factor, or whether it's due to a change in the hormonal milieu that happens after menopause, which again Dr. Oyoung discussed today at noontime. So I think those are the big areas of emphasis as far as, I think at this point we know that is the population that's most at risk from this entity of Takotsubo cardiomyopathy, and now it's, what can we do to prevent it?
Great, well, thank you. Yeah, this is an important one. And even if the patients do well, which is what we're thinking, they're still at a higher risk for morbidity, mortality down the line. It's not without its limitations. So now onward to arrhythmias. I think this is one of the most, palpitations is the most common symptoms that women present with. And we see PACs, PVCs, and atrial and ventricular arrhythmias. Should we be treating men and women differently, Noel?
So unfortunately, it's a very bad catch-22 because women have a lot more palpitations that are nothing, and they're also much higher for having serious arrhythmias and particularly sudden death because of the QT. They're much higher risk of having proarrhythmia from drugs that prolong QT. They have a lot of changes peripartum that make them much higher risks for sudden death. And so and the perimenopausal situation is problematic because it causes a lot more palpitations. And then, of course, now we know there's also higher risk of getting stroke if they have AFib. So there are a number of ways that women are at higher risk actually for an arrhythmia, even though they are more likely not to have an arrhythmia when they present with palpitations. So it's a very serious catch-22. Fortunately, the modern world, we do have now a lot more ways of monitoring, but I am amazed how often people have presented with palpitations numerous times and nobody ever even sent an event monitor. So we send event monitors for a lot of nonsense, and yet it's very, very important to.
So are
at
we
least-
ignoring women with arrhythmias, or are we
Again,
overshooting?
it's a
What
bit
are we
of a-
doing?
Since the majority actually do have nothing, it's kind of a difficult situation. Having said that, you can't hurt somebody by giving them a monitor. So it's such a low-risk thing to do. It amazes me that it's not done more regularly. Clearly, monitoring is improving. A lot of the monitors in the past were harder to wear, gave you more misinformation. So I'm very optimistic that in the near future, we'll have better answers. Also, as we're getting much, much better at integrating the data into our computers, we'll be able to crunch this data and attach it to clinical variables and probably start figuring out how to decide who should get the higher level
So is it,
monitoring, et cetera.
so I always find this 24-hour monitor, Holter monitor, to be low yielding, and maybe that's why we get nothing and we say they have nothing. And I wonder if a longer-term event monitor, some other kinds of testing that needs to be done when women present with palpitations. And then, importantly, what I want you to go into is more into the atrial arrhythmias, specifically atrial fibrillation, because the burden of atrial fibrillation is almost twice as much in women. It's a huge, huge burden in women, as we know, and probably because of hypertension, untreated hypertension, and that relationship. And are we doing
also
less ablation and less treatment of women with atrial fibrillation? And is that an area where we need to really focus to reduce the burden of disease?
So not only that, but you brought up sleep apnea, which is higher risk for AFib, and probably the microvascular disease also is scarring. We know more and more about scarring in atria equals more likely to AFib. So there are risk factors involved in there. So just in terms of the monitoring, there's a role for each kind of monitor, and generally you don't use a Holter to catch the palpitation. That doesn't make sense. Of course, the yield for getting the palpitation will be higher. However, the Holter can allow you to have much more specific and integrated data that you can go look at. So it's very useful, for example, and we talked recently about WPW to see if the pathway blocks with a PAC. Is much more useful to looking for sleep apnea. So it may have other roles. So generally, I use the Holter to look more deeply at specifics of the electrophysiology through a 24-hour period. So that's useful. But if you're trying to catch an actual arrhythmia, for certain, it makes more sense.
What
and now
about-
with the patches, it's easier.
What about, Dr. Kantorovich, what about channelopathies? Is that something we should be looking, or in whom and when should a woman have genetic testing for cardiovascular disease, whether it be heart failure versus arrhythmias versus coronary disease? Are there any associations that we might or should know about?
So I'll start with the channelopathy question. That's a really good example of where genotype and phenotype converge to medical decision-making. And in the long QT syndromes, female gender is associated with higher risk. So we're talking about congenital long QT, in addition to what Dr. Langen said about women at baseline having longer QTC's duration. In the long QT2 syndrome, female sex is associated with a higher risk of ventricular arrhythmia and torsade de pointe. And so in certain circumstances with the right mutation and the right QTC duration, if you're a woman, you've bought yourself a primary prevention ICD. Whereas the comparable clinical setup for a man would not necessarily warrant a primary prevention device. There are other examples in the long QT type 1s as well, where we consider gender and genotype to make these decisions. To get to the second part of your question, other conditions under which we should be thinking about genetic testing specifically for women. There was a recent publication about 2 years ago showing that the rate of truncating Titin variants in women with peripartum cardiomyopathy approaches what we see in the dilated cardiomyopathies. So there may be a genetic predisposition to peripartum cardiomyopathy that's under-recognized. And the same mutation in a pregnant woman may cause a dilated cardiomyopathy in her son or her brother. And so we should be thinking and taking a detailed family history among women who have peripartum cardiomyopathy, starting with them thinking about the rest of the family, thinking about doing testing. Other circumstances in the vasculopathies, that's certainly important. Certain genotypes obviously are higher risk for vascular complications. And in our program, when we see women with aortic disease, of course, we ask them about their prenatal history and also about their plans for impending pregnancy. And we talked a lot about getting the past history, but it's so important to also query about a woman's reproductive plans moving forward, especially if you're seeing someone in their reproductive years.
That's beautiful, very well put. So speaking of cardiomyopathy, we're seeing a very important arena being looked at, and maybe Pam, you can tell us specifically in women with preserved ejection fraction. The study with Entresto, just on Paragon study that was just presented at the European Society of Cardiology was unfortunately did not pan out to make any difference at all in the overall population, but there was questionable, maybe something interesting in women that we saw. Is there any reason to think that number one, why is preserved ejection fraction maybe more commonly seen in women as we're seeing it? We don't have much treatment options for these women or these patients at large, obviously, men and women. And is there a reason to think that there is something we should learn and think about differently, an alternative pathway, like we did learn from dapagliflozin in a diabetes drug that helped in reduced ejection fraction patients with heart failure?
There's a lot of questions there.
Just HFpEF and women.
So I think that the HFpEF itself, I think, has sort of heterogeneous disease. It ends up with shortness of breath, fluid overload, and a normal EF. But there's the group, if you see a lot of patients, there's the older woman, often with major obesity, hypertension. The group that's chronic kidney disease is another sort of phenotype. So that I think there are several different probably phenotypes within HFpEF. Certainly, there are studies that are animal studies indicating that removing estrogen, removing the ovaries, might affect pathways that affect cyclic GMP and PDE5 regulated. So that's one of the areas that we're investigating in animal models. And at Hopkins, we have a very active HFpEF clinic, and we are looking to exclude amyloid, so a number of them actually undergo biopsy. So there's a lot of tissue studies and RNA-seq and things like that that will provide some information going forward. So the women have higher BNP than men, and maybe the pathway might have a different feedback loop. And maybe this is one reason that drugs like Entresto may not be as effective. Hard to tell. HFpEF does just seem to be a much harder nut to crack than HFrEF, but I think it may be the heterogeneity of the population
That's probably right, isn't it? And a lot of that. So let's get to sex hormones. It's the biggest question that we all have. We're still being questioned, doctor, should I be on an estrogen replacement therapy in a postmenopausal woman? So maybe we should start from the end and come down this way. Who, if anyone at all, Gina, do you put anyone on estrogen replacement? What's the role of HRT in women, postmenopausal women? Are you worried to put them on?
Majority of my patients outside of imaging are congenital heart disease, so the answer for me would be no.
No, that's good, yeah. Marianne? This is your big area.
So the rules are we never.
Can you put on your mic, because this is what everyone wants
Right.
to hear?
So, no, we should not prescribe estrogen replacement therapy to protect the heart. The rules are that if a woman is having symptoms and it's within the first couple of years of menopause, and you do a thorough history and looking really for venous disease, so history of blood clotting disorders in the patient or their family member, then you can say that it's safe to use low-strength estrogen replacement therapy for 2 to 5 years postmenopausal. The problem was with the HERS trial was that patients in general were prescribed estrogen replacement therapy on average like 10 years postmenopause. And so that group was older, and that's when they had poor outcomes, especially the first year of taking estrogen replacement therapy. They had increased risk of MI and cardiac events. And so the people who survived, though, at 4 to 5 years, there's a survivor benefit, they did better. So it's still tricky, and I think that's one of the areas that a lot of women are looking forward to see if they would be able to take it for more long term. And in the GYN group, some women do go on and take estrogen for many years, but I would say in that group to really look at their other cardiovascular risks and make sure that they're taking a statin if they need to be on a statin if they're as we get older. And if the issue about aspirin is another one that it's a whole nother grand round to talk about aspirin in women and in men too. But so that's the latest recommendations are you don't prescribe it to protect their heart health, but if a woman has significant symptoms, they don't have significant risks, then they can go on it safely for a couple of years.
Sounds good. Danielle?
So I often get asked this question mostly from my patients who have had SCAD previously or have other arteriopathies. And in that setting, it's particularly interesting because the most common cause of myocardial infarction in postpartum women is SCAD. And there is a higher association in some patients that have taken exogenous hormones, at least in case reports. But it really hasn't been, I don't think, well understood at all. So the general recommendation is to try to avoid exogenous hormones if possible. And in those who have symptoms that are completely intolerable, the lowest dose possible in transdermal for the smallest amount of time as possible.
Does it make a difference if a woman has peripheral vascular disease? Do you look at that differently when you're considering hormone replacement therapy? You're not thinking at all about that. It's really just
much like the way
much
that
like
Marianne was talking about with cardiovascular
So
disease.
Pam, what's the word of the day? Do we or do we not?
I would agree with my colleagues on the left. There were a couple of studies that tried to look at this timing hypothesis of the hormones after the WHI came out. Both of them used carotid IMT, carotid intermedial thickness, as a surrogate marker. One of the studies showed that enrolling women that were within 3 years of menopause and randomizing them to either oral transdermal estrogen or placebo, there was no difference in the rate of progression of carotid IMT in those 3 groups. The other study looked at postmenopausal women who were either within 6 years, so the early, or after 10 years after menopause, or the late postmenopausal group. Again, estrogen replacement or placebo, and again, carotid IMT as the outcome. And there they showed that there was a less of a progression of IMT thickening in the early postmenopausal women on the estradiol group, while in the late postmenopause, the progression was not different with the estradiol versus placebo. I think that why those two gave somewhat different results is still unclear, but both of them would suggest that in the early postmenopausal, the risk is not major in a, as long as they don't have other contraindications to hormone therapy. So I think we can feel comfortable if the woman is so symptomatic from menopause that they can safely be on the hormone replacement. But again, it's the lowest amount and the shortest. And there's interesting, not a lot of studies have looked at the progesterone component, and that may also be of importance, particularly for breast cancer.
All right, well, that's great. I know that we're just 2 minutes before 6. I'm being really good at this because you need to make sure you get. I want to give one question at least to the audience for our visiting professor that you might want to ask before she leaves us. We've been so lucky to have you, but we're going to continue this. Just want to make sure. Dr. Friedman.
Yeah, so I don't do a lot of tertiary work. I do primary work mostly. And I got to tell you that I do have calcium scores on everybody at 3 points. One, it's remarkable to me how corrected for age, how through IMT studies, how relatively free women are of atherosclerosis by those studies. And that's supposed to be the most predictive, non-invasive thing to do. Second thing I would say on a primary level, not tertiary level, that my patients with small vessel disease and Takotsubo, they do incredibly well. They don't get sudden death and they don't get heart failure.
It's because they're your patients, but in general, they don't do well.
Well, I don't have confidence in that. But the purpose of this is controversies, number one. Number two, the purpose of this is to help those of us in the office who are stuck with the practices we have.
Right.
Okay, and the final thing is because it's primary care, in the middle of the night, you get a call, and you have to do a lot of work to be sure it's not a problem, right? And there's going to be a lot of indigestion, there's going to be a lot of stuff. And then you're looking at the top of the triangle here and saying, well, these are how these women present, but it isn't necessarily helpful for those of us who work in the gutter, in terms of how we're going to help our patients. So I'm just saying it creates a tension if you're listening to this, and this is all well reported, but it creates a tension of, okay, now what do I do?
Good, so we're going to give you some advice.
Good.
Dr. Oyan.
So I think there's a big difference between when you see the patient coming with the acute setting of Takotsubo. So that's where they're coming in heart failure, the risk of sudden death. The patients, a significant proportion of them, the LV function is going to go back to normal. So that when you see them as an outpatient, their exercise tolerance is fine.
We make a diagnosis in our office, and I appreciate how sick they are. But I'm saying, so you put them in the hospital, we confirm the diagnosis, and then, they do. You're not afraid for them like you are for lots of other patients.
Well, there are certainly the individuals with who have severe mitral regurgitation, who have come in with cardiogenic shock. Those are the ones who are doing very, very poorly. You're right, the majority of the patients who come in heart failure often, and then their LV function improves over the next several days. They put on their guideline therapies and are looking really good by the time they go home. So the majority do well, but the sickest of those patients are going to do quite poorly in the hospital. What was the first point you raised? Calcium scores. Yeah. So carotid IMTs, I think, are not very helpful in the individual patient.
Well, this is good. So we're gonna let. This is great. And Dr. Fuster. Yes, Dr. Fuster. Sorry.
First of all, to congratulate you. It's an excellent session, and to congratulate you as a moderator. I'd just like to make a comment. To me, what worries me most is the people in the street, not the people that we see in our offices and so forth. And what became clear, this was in Spain, where we developed a program which is affecting 25% of the women. We have buses in the cities that go along and women can get in and they have a checkup. This is having a tremendous impact. I think we have to go to the street. And I think that's one of the issues that I would like to convey, to become much more awareness of the problem of women in cardiovascular disease, rather than dealing in our offices, which is very fine, but this is not the problem.
That's right. I mean, I think that's the whole point, is to kind of bring out some of these statistics. I know they're daunting, and they seem like, wow, I don't see this. what are you talking about? But this is the truth. These are the real statistics. So I want to go back to Dr. Kinney, and then I'm going to ask you about PCI in women, just in a quick way. What do you do differently in a woman? And what should the clinicians here take home when they're referring these patients, these women to you? What are you thinking about? More dissections, more perforations, more calcific disease? You want to just discuss that and some of the bleeding avoidance strategies that you're using in the cath lab for these women?
Once the risk stratification has been done, whether you're done CTA, coronary calcium, or a stress test, and once they come to the lab, if you see disease, I think the way we manage them would be the same. There's no difference. But somehow, since they do have smaller vessels, so risk of dissection, bleeding is there, but there are ways to tackle these cases. But one thing is for sure, that women do have a tendency that if they show dissection in one vessel, that if you're doing another vessel, they do the same thing, that somehow the dissection will again repeat in other part of the vessel also. And of course, to avoid bleeding, they will be on antiplatelet therapy, no difference whether they are going to be on any kind of antiplatelet DAPT regimen, whether you have to go on Plavix or the newer antiplatelet agents. Once they have been done, how to avoid your bleeding, that your question was the same. We can go, instead of femoral, you can go radial approach, but we got to be very cautious. They do have smaller radial arteries also, and that's another thing that you should be concerned. I think one other thing that we never touched here would be that women, very rare, a small proportion of patients do have autoimmune disease.
Yeah,
and patients who do have autoimmune disease, we have seen them with aggressive coronary artery disease, and that coronary artery disease is very difficult to deal with. They have higher restenosis, and they come back with aggressive atherosclerosis when they come back, since I think they are not tolerant to statins, these patients. That's one group, and of course, if they have other autoimmune disease and thyroid, those kind of disease, they do have
So there's no question, we didn't touch on a lot of things because there's so much, all of cardiology in under 1 hour. But let's just take away some pointers, and I'll just go quickly and one by one. Just tell me what you know about these areas. It may not be your area of interest, I'm sorry, but just let's put it out there so that the audience gets it. Women with diabetes, what should we be thinking about? Dr. Fowd.
Yes. I think, again, for women with diabetes, it goes back to making sure that we have the appropriate therapy or equally intensive therapy as we can would do for men as well. Just discussing the diabetes for young women. The one thing I think most interesting I found was young women with diabetes, their risk for coronary artery disease.
It's the most important finding, exactly, that the young women, these are the diabetes in the young women is one of the biggest things we have to get around. Smoking in women.
Yes.
Amy, what do we do about the kids vaping? Girls, teenage girls. I have 3 teenage daughters. I've caught them all with the Juul.
I don't have an answer to that.
Just saying.
Yikes. No, but I think we can't ignore the stresses that women face in their day-to-day life and how that might impact their tendency to become addicted or to use drugs or other substances to relieve stress. And we should be in the office counseling about healthy stress reduction techniques. We should be asking a smoking history and offering tactics for quitting to patients who are smoking.
Dr. Kinney, single mothers, should we look at them differently and think about them with more care? You see a lot of them. We see them coming in the cath lab. And are you doing yoga experiments there for them?
I think it's a different level in the sense that their stress level probably is totally different. Going back to all of this, we are talking about is lifestyle, which is a key. And a lot of us do talk to them, but I think what is happening is, as physicians, we forget, we just do the easy intervention, but the most important intervention is a lifestyle modification, which nobody has a time to talk to these patients, and what we call psychotherapy is rarely given to them. That is how it changes. So if you're talking about young women, obese, smoker, who will later on in their life develop, what they really need is who's going to talk to them saying that, no, these things have to be changed. And lifestyle modification is not that easy, it's expensive. Healthy food is more expensive than unhealthy food. So they end up eating unhealthy food. So society
Danielle.
has to change, but I don't know.
Danielle,
how to
we
change
see
it.
often, and I can say for myself as well, abdominal obesity, postmenopausal abdominal obesity. Why does it happen more often? I mean, I know I see a lot of guys with beer guts too, but really we see more and more women, postmenopausal women, abdominal obesity, metabolic syndrome associated with early and progressive atherosclerosis. Why is it happening? What should we do differently? Do you go after them with something different than the usual, and what do you do?
So I approach them all very aggressively. I think by nature, being the vascular realm, we look at all of these patients as being extremely high risk. So attacking all of those risk factors is extremely important, in addition to the lifestyle modifications that was mentioned. In terms of why does it happen, I think it's a combination of poor lifestyle habits and probably changes in hormonal milieu as people get older, and lack of exercise as well, which is a huge issue. And it's hard to ask people to change everything when they're trying to just get by day to day and handle the stress in the best way that they know how, and then you introduce a new ask. So I don't know that I have an answer.
Marianne, lipid management in women, do you do something different for them? Are you measuring LP(a) in women? You know, there's the interesting risk of that in women.
That's interesting. I had a patient in my office today who has a strong family history of heart disease, and I thought, oh, I have to measure an LP(a), and I looked back and I actually measured it in 2002. So I've known him that long, so I said, well, at least I did something right then. Dr. Friedman probably taught me and Dr. Miller to do that, honestly. You guys are mentors here. So so I look at family history very strongly, and I think that's one thing that's very important, that patients know their family history. Because the reason to do it right now is to see how aggressive you're going to be with your LDL, right? There are certain medications are in the investigational stage to lower LPA directly, but if the LDL is in a relatively reasonable range, but your LP(a) is high, you're going to be very aggressive for both MI and stroke.
What's your ideal LDL for women?
So, optimal now is 100. So we go by the same, and the HDL will go up and down. If a woman's HDL is low, then we're even more aggressive in our care for them. Postmenopausal, we constantly see the lowering of the HDL, so we're still as aggressive with the women.
So you're watching that very, very good.
Right.
And how often do you measure C-reactive protein, and does it matter in women?
It's interesting. If I'm doing a full cardiovascular risk profile, I do it at least once, and then again, it goes along with obesity, it goes along with sleep apnea, and all those other things that you can treat. But I want to put a plug in one of the Dr. Fuster's articles, and people over the age of 75, when looking at the ASCVD risk factor, if you do the carotid intimal media thickness and the coronary calcium score, you can take people that you might have wanted to put on a statin, and if those are very, very low, then you can go along without a statin. So I use that in my office and tell people when they're very healthy and they're very low risk, we can look at those in addition to who really needs the statin with aging.
Noelle, syncope and hypotension in women, what do you do differently? If at all.
Try to figure out if it is hypotension and then refer it away. That's the right answer. But it's actually obviously very, very problematic because it has a two-phase period. So there's the early, younger people who have obviously their typical vasovagal, and then older, as the vasculature gets worse, we have a lot of the vasodepressor. And it, again, is very problematic because certainly, especially with the young people, particularly peripartum, where we have the vasovagal appearing and worsening, it's also the time when the QT gets worse. So it is really a problem for us that the cycles of the vasodepressor symptomatology also parallels often the risk of arrhythmia. And so really, a lot of it is trying to capture what's going on, which of course, sometimes you don't have much time to
Do you
that.
do more tilt table testing in women?
I
or
really
not?
do no tilt table
You don't do
testing
any?
at
Oh,
all.
right, there you go.
Yeah, I do none, because it truly is a diagnosis of history, watching, looking for the exclusions, and unfortunately, very poorly reproducible on the tilt table test. So it's not as helpful as I would like it to be.
It's good. And then last but not least, Gina, women with congenital heart disease, how do you counsel them when they want to get pregnant?
Such a large spectrum. So if you go
I know, it's a very
complex congenital heart disease.
vast topic here today.
Yeah. Depending upon how complex the congenital heart disease, single ventricle physiology is very complex. So depending upon the single ventricular function, any other history of cardiovascular disease, stroke, peripheral vascular disease, that all factors in, particularly aortic disease. So in that spectrum, we try to counsel them against it. It's a hard topic, especially in the young women population. Pulmonary hypertension goes along with congenital heart disease in the adult.
Yeah, we didn't even copy that. I mean, that's a huge
hard
piece.
topic. When it gets to that complex, I usually pull in my pulmonary hypertension colleagues, in particular Dr. Trivieri. Together we work with that.
She couldn't be here today, unfortunately.
It's a wide spectrum. If it's something simple, congenital heart disease, repaired, normal biventricular function, I treat them exactly as if someone's never had heart surgery.
Fantastic. Well, this has been an incredible discussion. We can see the amazing colleagues that we have here at Mount Sinai with so much expertise. Dr. Fout, you did a fantastic job covering a very, very difficult topic. Dr. Fuster and Dr. Goldman, thank you for allowing me to moderate this. And now we'll open this up to any questions. And for all the people who missed this session, I'm sorry for them because they got all of these tips and tricks in treating women. Okay, let's open this up.
So there's a significant number of women in their 40s and 50s that undergo radiation therapy for breast cancer. Do you change your screening strategies for patients that have had chest radiation?
That's a great question. Maybe, Gina, you want to take that, and then we'll ask Marianne?
Yeah, so for imaging, let's take something as simple as an exercise stress test. But if you want to get stress imaging, a SPECT or a nuclear stress test, you could try to do just the stress portion and avoid the rest if you think that there's low to moderate risk for the patient, lowering the risk of radiation exposure. Cardiac CT, if you think you have a low to moderate probability, you could avoid the calcium score. If a coronary CT is needed, use a really small field of view just over the heart and try to do prospective gating. Sometimes we only do one phase if the heart rate is really low. And then, of course, my favorite is cardiac stress MR, which has absolutely no radiation and has 96% sensitivity and specificity.
Great. Any other questions?
Hey, my name is Satish. I was a research fellow in the Framingham Heart Study for
good.
about 2 years.
Good.
4 years ago, when I was faculty, my mentor asked me to write a review article because he was a guest editor on some journal. So I was forced to write on the topic of heart failure in women.
You were forced. That's a very good. It's a very good topic.
That was not an area of interest, but I had to choose this topic. So in the process, I sat down for a whole week and reviewed every study published from the Framingham Heart Study. There were about 69 articles written on it. And I was surprised to find that men and women had more things in common than differences in terms of heart failure defined using Framingham Heart Study criteria. And what I found was the incidence of heart failure, that is occurrence of new cases of heart failure, is same in women and men, right? And surprisingly, women over the last 50 years of follow-up in Framingham Heart Study have a 33% lower incidence of heart failure. But men, it has not come down. So women are actually doing better in the Framingham sample. The other thing I found was the 8-year incidence of heart failure in men and women was the same. It's about 24% in both of them. In fact, it was slightly lower in women than in men. And even all the biomarkers, they had about 50 different biomarkers they had referred. There was no difference between women and men in terms of incidence of heart failure. There were some differences on the structure of the heart, but not on incidence. So I was wondering, when people are emphasizing so much, saying that women have higher incidence of HFpEF, for instance, compared with HREF, Framingham Heart Study is not showing it. In Framingham Heart Study, the HFpEF and HFrEF is occurring as commonly in women as in men. The only difference is men are having more HREF.
So are you suggesting that everyone is wrong and that the Framingham, is it because of the homogeneous population perhaps in Framingham, Massachusetts?
We have not been able to find out the reason why this is happening.
It's interesting.
HREF and HPEF is occurring equally in women, the incidence-wise. But prevalence is more. HPEF prevalence is more in women, but not in men.
Yeah, I don't know that I have an answer to that.
Prevalence is higher of HFpEF, but incidence is really not different from HPEF and HREF, which is surprising us in Framingham Heart Study too.
Yeah.
But what we see is what we see. We just try to find an explanation for it.
That's right.
So I was wondering if people here have any idea as to why.
Unfortunately, our heart failure gurus are not here to answer that question, but there's no question that after a myocardial infarction, we are seeing more heart failure in women than we do in men. And that's reduced ejection fraction, obviously, after an ischemic injury. And we're seeing, some issues with ongoing heart failure, progressive heart failure in women, and less of those women are being, the end-stage heart failure women are being evaluated for heart transplantation as compared to men, for whatever those reasons are. And those are just common statistics. And then, of course, then we have to go back in and dig into them and see, are there really true sex-based differences, biological differences, versus treatment biases and evaluation and treatment of the patients. So I think, I don't know that I would use the Framingham Heart Study as the Bible of what is really going on around the globe for women with heart failure. The data are the data. We get a lot of these data from the IHCME, where there is the international center where there is the global burden of disease is being evaluated for all kinds of ischemic, rheumatic, preserved ejection fraction, reduced ejection fraction from all parts of the world. And what I think you saw in the report from Dr. Fowd is what's there from the global sense. But it's interesting, I didn't know that about the, I haven't read your review article, so maybe that's what we need to do. Yeah, so that's good. Well, right, well, interesting. Any other questions? Well, I want to thank you all for being here, and I want to thank Dr. Goldman for choosing this topic, and Dr. Fuster for your support, and thank you for these amazing, amazing colleagues here.